neurologist. Sorry. My name is Ben Tolchin. I'm a physician and neurologist and a medical ethicist at Yale New Haven Hospital. I'm direct the Center for Clinical Ethics in the Yale New Haven Health System, and I'm the president of the New England Epilepsy Society. And one of my clinical and research focuses is on functional or psychogenic seizures, which I was asked to speak to this group about tonight. I'll try to talk for maybe 20 or 25 minutes and then invite any questions or comments from the group. I'm happy to address questions either during the talk or at the end. Either way is totally okay. I'm happy to engage in some discussion as we're going through if something jumps out at you that you'd like to talk about. Just in terms of disclosures, our clinical research is supported by the C.G. Swabilius Trust, and there will be no off-label uses of medications discussed in this talk. So the objectives for this talk is for participants to be able to describe the risks of untreated functional or psychogenic seizures, for participants to be able to summarize the evidence for cognitive behavioral therapy in the treatment of functional or psychogenic seizures, and for participants to be able to identify strategies for neurologists to facilitate psychotherapeutic treatment of functional or psychogenic seizures. And so to begin, I just want to say something about the terminology. So there are a lot of different terms used for this disorder. Historically, the term pseudoseizure has been used, and you may hear some clinicians use that term, or you may see that on the internet or in a book. Nowadays, I would say the most common term used is psychogenic seizure or psychogenic non-epileptic seizure. Many patients, family members, and researchers have indicated that they prefer the term functional seizure. And so for the purposes of this talk, I'll use that term, but really these different names are interchangeable and identify the same disorder. So over the past decade, there have been some really remarkable advances in the treatment of these functional seizures. So what are they to begin with? Functional seizures are transient episodes of altered awareness or involuntary movement that are not associated with epileptiform discharges on an electroencephalogram or EEG. Functional seizures can look and feel a great deal like epileptic seizures, and I'll show you in a couple of minutes an example or two of what they can look like, and they can fool both experienced neurologists and also the patients themselves. Even patients who have epileptic seizures, who experience functional seizures, may sometimes not be able to tell which seizures are epileptic and which seizures are functional. But unlike epileptic seizures, functional seizures are not caused by epileptiform discharges in the brain. They are thought to be caused instead by overlapping psychological, social, and biological factors. And severe life events such as abuse or neglect are identified in 91% of patients. So most, but not all patients, and are thought to play a role in causing these functional seizures. And in addition to severe life events, there is a growing body of fMRI or functional magnetic resonance imaging research, which demonstrates altered functional connectivity in the brains of individuals with functional seizures when compared to individuals without functional seizures. As of yet, this is really only on a research basis when fMRI is done on groups of patients. So when multiple patients are compared to multiple individuals without functional seizures, you can see these differences. Currently, the fMRI differences are not proven for use in diagnosing individuals. And so the diagnosis really remains, for now, video EEG capture of all typical episodes and evaluation by a experienced neurologist looking at the video and the EEG of these events. Importantly, functional seizures are, in the overwhelming majority of cases, are involuntary. They are not controlled by the person who is experiencing them. And in fact, an important part of the cognitive behavioral therapy is to give patients both more awareness of when they are moving towards having a functional seizure as stress and other strong emotions build up, and also gaining more control over that stress and other strong emotions in order to prevent functional seizures. Functional seizures are a common and particularly disabling form of functional neurological disorder or conversion disorder, which is sort of the broader category. And although the prevalence of functional seizures is relatively low, individuals who have functional seizures come into frequent, repeated contact with the healthcare system. 25% of patients who are monitored in epilepsy monitoring units are ultimately diagnosed with functional seizures. And more generally, up to 16% of patients who present to a neurology clinic are ultimately diagnosed with one form or another of functional neurological disorder, including functional seizures, but also other functional neurologic disorders. And so now I'm going to just pause here and say I'm going to show a video of a very typical functional seizure. This is shared with the patient's consent. Videos of seizures, functional seizures, can sometimes be distressing to folks, and so I just want to give a warning before I show the video. If you want to turn off the video, I'll say when the video is over. But I'm gonna show this video. This is a young man who is having a functional seizure. This is not in his control. He's in a hospital being evaluated, and he's experiencing some involuntary movements of his right hand, and he pushes a button to notify the nurses that he's having an event. And the nurses come in and turn on the lights and start talking to him. Now, he is not able to respond to the nurses. You see this nurse is sort of talking to him and prodding him. He's not able to speak back. He's not able to respond to her questions or her touch. And these movements that he's having are involuntary. And you may be able to appreciate that these movements can look to an untrained observer quite a bit like an epileptic seizure. And in fact, this patient was, under the impression he was having epileptic seizures before he was evaluated in an epilepsy monitoring unit. And these movements are continuing. They last for, in this case, about 2 minutes. The patient later reported that he was partially aware that people were in the room with him and partially aware that people were talking to him, although he could not understand what they were saying, and he could not respond or follow their commands. And now he's contracting, and that sort of brings an end to the episode. And I think he begins to relax at this point, and I'll stop the video here. And so that's an example of a fairly typical functional seizure. I have another video that shows a slightly more dramatic version, but I'll hold off on that. If people are interested, I can show you the other video later on during the question and answer session. But I want to move now to some other topics. So we know that the cost of untreated functional seizures is very high for patients, families, and society. In comparison to people with epilepsy, people with functional seizures report a worse or lower quality of life. The majority of people with functional seizures, 67%, are unemployed at the time of diagnosis, and 56% received disability payments. And at 5 to 10-year follow-up, 55% continue to have functional seizures, 70% are unemployed, and 67% are on disability. So in the absence of treatment, this is a very disabling disorder. In addition, a Danish study that looked at patients with functional seizures on a population level, because in Denmark, they have national registries. And so they're able to look at everybody who's been diagnosed with functional seizures in the country. And they were able to, looking at this population level evaluation, they were able to estimate the cost of lost earnings due to underemployment at $18,500 US dollars per patient per year, which was quite high and even exceeds the cost of the medical and psychiatric care that those patients were receiving. In addition to the costs for patients and families and for society, there's also a growing body of evidence that suggests patients with functional seizures experience higher rates of mortality, meaning that they die at an earlier age than individuals without functional seizures. In a study by Dr. O'Brien in Melbourne, Australia, people with a functional seizures had a mortality ratio 2.5 times that of the general population ratio. And that was not statistically different from the standardized mortality ratio of 3.3 for those with medically refractory epilepsy. So what that means is that folks with functional seizures were dying prematurely at a similar rate to folks with severe epilepsy when compared to sort of the general population. Among people with functional seizures, the mortality rates were especially elevated in younger individuals and then gradually normalized over decades, with the relative risk of mortality dropping from 8.6 for those under 30 down to 1.5 by age 60. Common causes of mortality among those with functional seizures included suicide and accidental drug and medication-related poisonings. Fortunately, there is a growing body of evidence that psychotherapy and cognitive behavioral therapy in particular is effective in treating functional seizures. So in 2020, Goldstein and her research group in the United Kingdom published the landmark multi-center randomized CODES trial of cognitive behavioral therapy for the treatment of functional seizures, involving 27 sites and 368 participants across the United Kingdom. The trial compared 12 weekly sessions of cognitive behavioral therapy plus standardized medical care to standardized medical care alone. And of note, standardized medical care in this study included psychiatric evaluation, but no cognitive behavioral therapy. Although the participants in both arms improved from baseline in terms of their frequency of functional seizures, there was no statistically significant difference between the study arms in the primary outcome of monthly seizure frequency when measured at 12 months. At six months, there was a significant difference, but by 12 months, both groups had dropped down in terms of the frequency of their functional seizures to a point where there was not a statistically significant difference. However, participants receiving cognitive behavioral therapy did have statistically significant improvements in numerous secondary outcomes, and that included quality of life, psychological distress, psychosocial functioning, seizure bothersomeness, somatic symptoms, so physical symptoms, patient-reported improvement, clinician-reported improvement, and patient satisfaction with treatment. And so this landmark trial, in combination with smaller prior studies, suggests that patients with functional seizures derive real benefit from cognitive behavioral therapy, especially in the domain of quality of life and psychosocial functioning. So given the high costs associated with functional seizures and the benefits offered by psychotherapeutic treatment, it's critical for neurologists to collaborate with mental health clinicians to expedite and facilitate treatment. Because mental health clinicians are often not trained to diagnose functional neurological disorders and distinguish them from neurological disorders, the neurologist plays a critical role in making the diagnosis, communicating it to the patient, the family, and to other clinicians. And this is a a painting of the Salpêtrière and of Charcot, who's a famous neurologist, who did early research in the diagnosis of and treatment of functional seizures. And these are a group of neurologists at the time. Among them actually is Sigmund Freud. Um, So neurologists can use the criteria published by the International League Against Epilepsy to make the diagnosis of functional seizures on the basis of history, semiology, which is what the seizure looks and feels like, and then EEG findings. More extensive evidence allows a greater degree of certainty in making the diagnosis, ranging from possible to probable to documented or definite functional seizures. In particular, video EEG capture of all typical events with no epileptiform discharges immediately before, during, or following the event is necessary to make a diagnosis of documented functional seizures. Importantly, the diagnosis does not require the identification of a psychological stressor, which may only become apparent after extensive psychotherapy. It's ideal to make the diagnosis with the greatest possible degree of clinical certainty, but in cases where extended video EEG is not available, or where seizure events are very rare, psychotherapy can be initiated for a diagnosis of probable functional seizures based on the semiology or appearance of the seizures, the history, and EEG obtained interictally, meaning between seizures. Once the diagnosis is made with the greatest possible level of clinical certainty, the neurologist needs to communicate the diagnosis in a respectful, empathetic, and clear manner to the patient, the family, and to other clinicians. Ideally, this should not come as a surprise to the patient, but should be part of a differential diagnosis that has been previously discussed. And the starting place for delivering the diagnosis should be sincere empathy for the patient's experiences. While the etiology of these seizures is different from epileptic seizures, the suffering the patient is experiencing is no less real. And impatience, disdain, or dismissiveness on the part of the neurologist or other clinicians really undermines the therapeutic relationship and the treatment of the functional seizures. And it is important to emphasize that the patient is not faking or crazy. These are a common symptom, and it is outside of the patient's control. And the point of treatment is to try to give the person experiencing the functional seizures greater control over these events. In a randomized controlled trial, we examined the effects of a 30-minute session of motivational interviewing prior to referral to psychotherapy. Motivational interviewing consists of reflective listening and other patient-centered techniques used to explore a patient's own motivations for and against a specific behavior, such as engaging in psychotherapy. Motivational interviewing techniques can be effectively learned from a workbook, an online course, or a peer study group. We found that participants with functional seizures who were randomized to receive motivational interviewing from a neurologist prior to the initiation of psychotherapy had better adherence with psychotherapy, a larger reduction in functional seizure frequency, and a greater improvement in quality of life at 16-week follow-up. And so this is a technique that can be used in combination with cognitive behavioral therapy. In addition to using motivational interviewing techniques to help patients engage with psychotherapy, neurologists can take several other steps to facilitate successful psychotherapeutic treatment. Neurologists can communicate directly with psychotherapists providing treatment, ideally by phone in addition to a written report, to explain the diagnosis and to preemptively offer guidance for handling a seizure in the office. In many cases, psychotherapists are familiar with cognitive behavioral therapy, but not with functional seizures, and are enormously reassured to learn about the disorder from the diagnosing neurologist. Once the diagnosis is made, it is often helpful for the neurologist to follow patients with functional seizures for at least a couple of clinic visits to ensure that they transition successfully into psychotherapy. Even after that, it is important for the neurologist to remain available for as-needed consultations in the event that new seizure types or other symptoms develop, which the psychotherapist may not be trained to evaluate. By working together as a collaborative team with the patient, the family, and mental health clinicians, neurologists can ensure that patients with functional seizures obtain evidence-based psychotherapeutic treatment that they need. In terms of the impact on clinical care and practice, functional seizures are associated with lower quality of life, underemployment, and increased mortality. I think that's one key takeaway message. Cognitive behavioral therapy is effective in improving quality of life, psychosocial function, psychological distress, and somatic symptoms among patients with functional seizures. And neurologists can use motivational interviewing and other techniques to collaborate with mental health clinicians and with patients and families to support successful psychotherapeutic treatment of functional seizures. And with that, I'll pause and stop and address any questions, comments, or concerns that the group may have.
Um, so far, no questions.
I'm happy if there are particular things that I went over quickly or that people would like for me to expand on, or if people have questions about the condition, I'm very happy to address, but if not, that's also fine.
I have a question.
Sure.
So are there any like lifestyle changes or coping strategies that can help reduce the frequency of the seizures?
Yeah, so I'll say, in our practice, what we do is we refer patients both to cognitive behavioral therapy. So that's typically a 12 session, um, a, 12 sessions of weekly psychotherapy where they're focusing on first developing awareness of stress and other strong emotions, identifying triggers that for functional seizures, and then developing coping skills. And the coping skills can include things like meditation, focused breathing, whole body relaxation, sensory distraction. So some people will use, for example, like lavender scent or a soft object that they'll touch. Removing oneself from a triggering situation, so like leaving a situation that is triggering. Now, in parallel to that, we will refer patients to a lifestyle medicine group, and the lifestyle medicine group will cover topics including exercise. So getting regular physical exercise is enormously helpful in terms of lowering stress level and providing a coping mechanism. They will focus on diet, so having a low glycemic index diet with plenty of fruits and vegetables. They will focus on socialization, so having multiple social contacts that one can turn to for support and for discussion. All of these, I think, can be very helpful. And so we actually do refer patients with functional seizures specifically to a lifestyle medicine group to address those strategies in addition to the sort of standard cognitive behavioral therapy that we have these patients do.
Okay, thank you. I see
Absolutely.
Laurel has a question. I mean,
Hi, Laurel. I'm not sure. Laurel, are you speaking? I'm not able to hear.
Um, Laura, you can also put your question in the Q&A box in the bottom and I can read it for you.
Hello.
Oh,
Hi,
yeah.
hello.
Mhm.
I'm sorry, my phone wasn't working properly. Um, I have a question. I have I'm gonna say epilepsy, and
Okay.
I keep passing out and passing out. Sometimes I'm gonna say I forget to take my meds. I have headaches, and um, what do you think that caused by?
The epileptic seizures. So epileptic seizures we know are caused by abnormal electrical discharges in the brain, um, which can spread from a small focus to over a wider area of the brain. And so the medications that are usually prescribed, now I don't know in your case what medications are prescribed, but usually the medications that are prescribed for epileptic seizures, the goal is to try to suppress those abnormal electrical discharges and prevent them from spreading when they do occur. And so if you take the medication regularly, in the majority of cases, the medication is able to prevent those electrical discharges from spreading to the point where you have an epileptic seizure. And so that's sort of the goal of the medications. One thing you might want to talk to your doctor about is um, strategies to help remember the medications. I don't know if in your case, if you're finding that you're forgetting the medications or that you're having side effects that make you not want to take the medications. But either of those issues can be addressed by your neurologist. If it's a problem of forgetting the medications, often pill boxes can be very helpful, or alarms. If you have a smartphone, setting alarms for when you need to take the medication can be very helpful. On the other hand, if it's a problem with having side effects, then talking to your neurologist about the side effects that you're having, they may be able to either adjust the dose or even change to a different anti-seizure medication that does not have those side effects.
Well, my neurologist is just retiring, so going to be having a new neurologist, and I cannot even take them. When I do remember to take the medication, I cannot even take a walk by myself. And if I just walked up the street like for 5 minutes, I'm having dizziness, and
Mm-hmm.
I'm scared to walk up the street by myself. I'm scared to pass out because I usually
Yeah.
pass out, if I walk by myself, and like you said, to set the alarm clock. I will set the
Uh-huh.
alarm clock, but I'm not gonna lie. I will forget to take the medication if I, just say I'm gonna use the bathroom real quick. I'll come back and don't remember to take the medication. I can't sleep at night because I will like take the medication sometime at 8:30 or 9 o'clock. And when I do go to sleep, I'm waking up late at night and cannot sleep. I
So
wake up really late, cannot take the medication. And when I do wake up, that I'll be so tired, you know.
yeah,
So I
so
don't know
so a
what to
couple
do.
of things in your case. So I would definitely talk to the new neurologist. I understand your old neurologist is retiring, so you want to get a referral to a new neurologist. Um, Again, I don't know what specific medications are prescribed in your case, but I will say that some of the older anti-seizure medications are more sedating, and can cause lightheadedness and dizziness of the sort that you're describing. And so sometimes changing from an older seizure medication to a newer seizure medication, uh, it won't be necessarily more effective at controlling seizures, but it may be significantly less um, sedating and causing significantly less dizziness and lightheadedness. So that issue that you're describing where you feel unsteady walking down the street after you take your medication, that could potentially be addressed with a new anti-seizure medication. Some of the newer medications have less of that kind of side effect. Unfortunately, no anti-seizure medication is entirely without side effect. So it's something that you got to do carefully with the supervision of a neurologist, but transitioning to a newer medication or adjusting the dose of your existing medication might be helpful. In terms of forgetting the medication, I totally understand that it's people really struggle. Everybody really struggles with remembering the medications. In addition to setting an alarm on your phone, having a pill box might be helpful. And generally speaking, I mean, I don't want to speak for your neurologist, but you might talk to your neurologist about what to do if you forget a medication temporarily. Often neurologists will say, if you forget the medication, take it as soon as you realize you've forgotten it and try to get back on track to maintain a therapeutic level of the medication. But that's a discussion you should have with your neurologist.
And also, at home, I'm scared to go on the stove, like to make something to eat because I'm scared to leave the stove on. And at home also, you know, say for example, I'm scared to, I'm not gonna say I'm scared. I get dizzy when if I try to mop the floor myself, and things like that. I'm scared because I don't want to pass out and stuff like that, you know?
Yeah, so it sounds like you may be having some pretty significant sedation and toxicity from the seizure medication. And so a dose adjustment or even a switch to a different medication might significantly improve those symptoms. I don't know, but that is one possibility to explore with your neurologist. And you might be able to get a similar level of seizure control with less of that sedation and dizziness and feeling of unsteadiness than you have right now. Because we definitely do see that, particularly with some of the older seizure medications like phenytoin, Depakote,
My
whereas some of the
sister told me,
newer medications have less of that sedating and dizzying effect.
yeah, my sister told me not to take the Depakote because that medication is not good for me.
Okay.
So I don't know what to do. Just next appointment I have is not until 4 months.
So it might be reasonable, since your neurologist is retiring, it might be reasonable to call your neurologist's office and ask if it's possible to get a referral to a new neurologist now and start that transition sooner rather than later.
Okay. Thank you.
Sure thing. Absolutely. Other questions from the group? I think that might be. If not, I think, Amy, if there's nothing else from you, we can wrap up. I'm happy to
I
address any
don't,
questions.
it looks like we only have the 2 attendees.
Okay.
I don't see any other questions.
Okay.
Oh,
Well,
but thank
thanks
you,
very much for
Dr.
having me.
Zulshin, for your time. This was
Of
great.
course. Sure thing. Take care. Have a great night. Bye-bye,
You as
folks.
well.
Thank you.
Thank you. Thanks, Laurel. Bye-bye.
Bye bye.